Good evening, everyone. First of all, it's really fantastic to see how many people have met up today. I think as SCI staff, each and one of us bring with us the accountability for the support that you provide us. And I think this is an excellent opportunity for us to bring feedback to you on how that support is managed. I'm going to speak to you about the collaborations that SCI forges with partners, and that enables us to provide treatments at scale and with impact. Now, this is just a few slides for the background of this talk. This is a very common situation in many countries where few people have access to tap water. And what seems like a pretty harmless situation actually contains a number of risk factors for a number of diseases, such as freshwater snails that act as intermediate hosts for schistosomiasis, so-called black flies that can transmit another disease, onchocerciasis, or river blindness, mosquitoes that transmit a number of diseases, including lymphatic filariasis, and then poor sanitation, which is a huge problem and leads to intestinal worms and schistosomiasis. SCI focuses mainly on providing treatments for schistosomiasis and intestinal worms, although as you will see, we partner with other organizations to provide treatments for also other diseases. And because these diseases are commonly neglected by the global community and even difficult to identify for the communities at risk of infection themselves, these diseases are typically named neglected tropical diseases or NTDs. The programs that we put in place to treat these diseases have a number of steps in common. And first step is to map the disease distribution. Secondly, to establish a strategy for treatment. There's drug procurement and logistics, the training of the drug distributors, and information provided to the communities that we are targeting for treatment, provision of the treatment itself, and importantly, reporting of the impact of treatment. So this is a pretty standardized program that we deliver throughout our countries. So I'm going to give you an overview over the partnerships that we have and that enables us to put in place these programs, and then give you examples of how partnerships actually enable us to plan programs in countries where we previously haven't provided treatments, and also to deliver those treatments, to strengthen control in countries where we provided treatments for a number of years, and how partnerships also are helping us move towards elimination in countries where we've been providing treatment for up to more than a decade. And finally, some interesting partnerships and opportunities and challenges that we managed to address with those. The national ministries of health and also education are really the cornerstone partners of any SCI program. And we spend a lot of time and resources on establishing excellent relationships with these national ministries. And we work across a range of countries in the whole of Africa, from the west of Africa to Eastern Africa and the Yemen, and also in Southern Africa. And as this example shows from Madagascar, we really work across a range of the sectors, both the health sector and the educational sector, from the national ministry staff to teachers, healthcare professionals, and community health workers that are trained as drug distributors. Human development is, there are three main components of human development, one of which is education. In the United Kingdom, a child that's enrolled in primary school can expect to receive more than 16 years of education, whereas the average in SCI program countries is less than 12. There's been a number of discussions on how, to which extent, treatment of worms actually contributes to improved education, but we do have evidence that it improves at least school attendance. And in order for us to reach to these children, we have to know where the disease is located. And one of the largest disease mapping projects that SCI has supported is in Ethiopia. One of the strongest aspects of the program in Ethiopia is the genuine commitment by the National Ministry of Health and as you can see, the Ethiopian Public Health Institute. And an example of that strong collaboration with SCI is that our program manager for Ethiopia is actually based, who's called Michael French, is based in Addis Ababa in the offices of the Ministry of Health. And so we, together with PCD, the Partnership for Child Development, also based at Imperial, and Evidence Action, provide the technical expertise, and other support is provided through other partners, including the Ministries of Health in Kenya and Uganda. And then we have the great support of funders, including DFID, recently CIF, and the END Fund, as well as a number of private donors. And altogether, all these partners work together to provide what will be targeted for the next, over the next 5 years, up to a total of 100 million treatments. This is a picture showing the school children that are targeted for the mapping project. And this shows one of the most common findings in so-called urogenital schistosomiasis, which is bloody urine, as you can see in these spots, as compared to the normal clear urine here. Another factor of human development is access to healthcare. The life expectancy at birth in the UK is more than 8 decades, or more than 80 years, whereas in SCI program countries, the average is more than 2 decades less. Obviously, this in part reflects access to adequate health services, and a part of that, filling that gap, is obviously providing treatments for diseases such as neglected tropical diseases. The Democratic Republic of Congo is another program country of SCI, and it is really a huge country with an area 10 times the size of the UK, and nearly 80 million inhabitants, and is really one of the very poorest countries in the entire world, in part due to a long-lasting conflict where the UN peacekeeping operation has been present for nearly 2 decades. I think one of the unique assets of SCI is that we harbor both high-level expertise, and we are also present really in the field until the youngest of our beneficiaries. As we can see an example of here from the DRC and the program manager, Sarah Nagaro. And Sarah has contributed to establish the first MDA, or mass drug administration, so the first treatment program ever to take place in the DRC, where stakeholders came together and questioned and discussed the availability of resources such as drugs, funds for distribution, and capacity for the distribution. And they came to the conclusion that they should develop this program based on an existing structure for the river blindness treatment program, and to provide this so-called integrated NTD control, which is really the ideal way of providing treatment, because you're providing treatment not only for one disease, but once you've put in place a program structure, you're actually delivering treatment for a number of infections that people are commonly co-infected with or infected with at the same time. This is another example from DRC where we are partnering, SCI is partnering with experts in other African countries that are providing capacity building in DRC. And although we are aiming to treat more than 5 million people by 2017, there is still a substantial gap as to the number of people in need of treatment, which is representative for a number of countries that we work in. The third factor of human development is the potential for income generation. In the United Kingdom, the gross national income per capita is more than 35,000 so-called standardized dollars, whereas in SCI, or the average in SCI program countries, is less than 2,000. This is probably a very apparent inequality that we know of, but it actually poses also a huge burden on our programs, because the national programs do not have the resources to fund the health budget from their own funds, and therefore jeopardizes the sustainability of these programs. So in countries such as Niger, where we've been working for a number of years, actually more than a decade, it is really important for us to influence the government to prioritize the NTD control program that we are supporting, so that we increase the probability or increase the sustainability of the program. In more than 18 million treatments have been delivered in Niger, and Anna Phillips, who's the program manager for Niger, supported a remapping project between 2011 and 2014 to identify those areas that still need treatment. And in a stakeholder meeting in late 2014, stakeholders came together to define this new strategy based on the mapping results. This is a picture from the mapping that took place in Niger, and it is really a huge country, with a large part of it being covered by desert, and not always in areas, as you can see, that are as secure as we would like them to be. And I really think this picture shows the dedication of the local staff in actually getting these programs implemented. These are the results of the mapping, and as you can see, there are some areas that are non-endemic. It's not so easy to see this laser. And then in the lighter orange color, low endemic, and still some areas with medium prevalence. And at that stakeholder meeting, all the partners brought together their challenges on how to actually strengthen the control in this country. One of the challenges is to treat people in urban areas. Thanks. In urban areas where perhaps the social norms are different from the rural areas where we are currently most used to treating. Treatment of nomadic populations, treatment of remaining so-called transmission hotspots, so areas where the prevalence still remains high despite a number of years of treatment. And also the insecurity in the country has led SCI to work in different ways, for example, inviting the program managers from in-country to London for planning and organization of the control program. Access to the benefits of human development is not necessarily evenly distributed across any given country, as illustrated by the so-called inequality-adjusted human development index. In the UK, that imbalance is very slight, whereas in SCI program countries, there is a substantial inequality in access to benefits. And in countries such as Uganda, it is more important than ever that we are actually able as an organization to reach those parts of the population with the poorest access to these benefits, such as health services. SCI has been supporting treatments in Uganda, as you heard from the first video, since 2003, and a total of 10 million treatments have been delivered. The control program is managed by Yoliza Nalula, and is put in place in partnership with DFID, RTI, and the Envision grant. And in Uganda now, selected areas with low prevalence are targeted for elimination. So this is what the map of prevalence of disease looks like in Uganda, and what Nalula, or Yoliza, has done with her team is to map the country now at a more detailed level than before, and able to actually address those remaining hotspots, and to treat and to report treatments from a more detailed level in the country. This also includes use of a novel schistosoma rapid test that gives a more precise description of the disease situation in the country, and that we will hear from the next presentation is increasingly used in mapping. Finally, some challenges and opportunities. I think one important challenge that we as an organization have to address is to manage the publicity of any events that occur in relation to an MDA. There might be events that occur coincidentally with the treatment campaigns without there necessarily being any relationship or any causal relationship with the treatment, and there might be effects that actually occurred due to the treatment, although that is rare. what we've seen happen actually in Malawi during the first SCI-supported mass drug administration in 2012 was that a small boy passed away a couple of days after the treatment campaign. And the autopsy showed that there was no relation between the cause of death and the treatment, but by then, media had picked up on this story and had created a huge negative attitude to treatment campaigns, and the consequence was that the local community from then on refused to accept the treatment. So what SCI had to do, and the current program manager, Jane Whitten, was to strengthen the training that we already do in order to prevent, in order to manage potential situations like this, to train the drug distributors to identify and manage suspected side effects, and to make sure that any side effects or suspected side effects get reported and followed up by the Ministry of Health and the World Health Organization. I think a very interesting approach to solving this issue was also following up with a collaboration with the broadcasting company that had generated this negative attitude in the first place, inviting them to broadcast prior to the following treatment campaigns. And this is a picture from one of the following campaigns where the national program manager is explaining the potential benefits of treatment and also the documented safety of distributing drugs to the same broadcasting company, and reinstating the confidence and trust to the treatment program in Malawi. And finally, an opportunity that Sarah is working on in another of her country, in Cote d'Ivoire, tapping into the huge potential of a broad access to mobile devices that we see many places, including in the countries where we are working. For example, to provide reminders of treatment dates. And that can be done on the most basic mobile phones through SMS services, reminding people of the date of the treatment, or also including health messages such as hand washing and so on. Finally, we are really hugely grateful for the support that we are provided with and that enable us to put in place these programs together with the national ministries, local and global partners. Thank you.